All right. Well, good evening, everyone. Thank you for attending this program. My name is Anna Kate Bush, and I'm the Neuroscience Operations Manager at Allina Health. Today's presentation about deep brain stimulation includes, so it looks like Dr. Orehek, so there's still people in the waiting room. I'll wait 1 second. Thank you.
I
can't see that.
They need to be admitted.
All right, thanks, Jocelyn. So tonight's presentation is about deep brain stimulation. This will include Dr. Eleanor Orehek, who's a movement disorder specialist at the Noran Neurological Clinic, and Dr. Kyle Nelson, who's a neurosurgeon at Metropolitan Neurosurgery. To start things off, Dr. Orehek will provide an introduction about deep brain stimulation as a treatment option for Parkinson's disease and essential tremor. And then after that, Dr. Nelson will share details about how DBS surgery works and what it looks like. At the end, you have the opportunity to ask questions, come off mute and ask questions, or put them in the chat if you'd prefer them be read. And it should be an exciting conversation, and hope it's as educational as possible for everyone. With that, I'd like to introduce Dr. Orehek.
Thanks, and good evening, everybody. Good to see you. And we used to do these programs in person, and then as a lot of things changed with the pandemic, we're doing these virtually. And if you look outside, it's probably a good night to be at home and not trying to make it out to an in-person program. So I think it'll still be good and hopefully interactive with questions at the end. Let me share my screen here. So I'm going to start off talking about deep brain stimulation as it relates to Parkinson's disease and essential tremor, and then go through kind of the workup and how we decide who's a good candidate. And then Dr. Kyle Nelson will talk about this more nitty-gritty surgical details of the whole process. So with an overview, so DBS is the acronym, deep brain stimulation. So it is what it sounds like, where we have to stimulate deep into the brain. So to do that, again, Dr. Nelson will go through how we get the electrodes deep into the brain. But once they're in there, it's connected to a battery that sits like a pacemaker in the chest, and then that creates stimulation that stays on and can modify some of those brain circuits that start not working well in diseases that cause movement problems, like with Parkinson's or tremors in the case of essential tremor. And it's probably one of my favorite therapies to be involved in, just because it can be so effective and life-changing and can give fairly immediate results. So it's a really cool therapy. It's definitely not something that we take lightly, and it's still brain surgery. So it is an intensive evaluation and discussion that we have with patients. So it's good that you're here. This is a good start to the conversation and just learning more about it. But there's definitely a lot individually that goes into deciding whether it's the right therapy for you. If you have Parkinson's disease, things we look at are how well your symptoms respond to carbidopa-levodopa. So that's a medication I'm sure you're familiar with if you have Parkinson's. And I'll go into a little bit more of this in detail in a little bit about the medication and how we figure out how to tell whether the symptoms are responsive. But generally, the symptoms that are treated well with the carbidopa-levodopa are the ones that we would expect to improve the most with the deep brain stimulation therapy. If you're having a lot of fluctuations in how well your medication is working, then that's when we definitely want to start looking at other options, because it's just hard to keep your symptoms in that sweet spot on just the pills or the medication alone. And typically it takes at least 5 years into the disease. That's from diagnosis. Symptoms of Parkinson's can start, we know, years before. So we look more at time of diagnosis and then living with that for usually at least 5 years is when people start to become more good candidates for therapy. So this is a graph that gives you another idea of what we look at and when we want to start looking at intervening. So it's definitely something we are utilizing earlier in the disease course than we used to, where it used to be more advanced stage Parkinson's was when we would start looking at using DBS. But we've seen with studies and monitoring patients over time that people seem to do better with that years left after surgery with if you intervene before it gets to the later stages. So we obviously don't want to take the surgical risk too early in the disease when the medications are still working well. So that's when you're in this more mild stage and you have a big therapeutic window of when those medications are working. And then over time, that window gets narrowed, and that's when you might see some of those off and on periods where the medication kicks in, but it creates side effects, or you get the wiggly movements like dyskinesias, and so it gets harder to tolerate higher doses. And then also medications can wear off unexpectedly or earlier than you'd like, or you need to take frequent doses to stay in that window. And so that's when you're in that more moderate stage and when we start looking at deep brain stimulation or intervening with other therapies. So symptoms, as I was saying, that respond well to carbidopa levodopa and then also respond well to the DBS would be things like tremor, although other symptoms, there's a lot of patients, up to 30% of Parkinson's patients don't have any tremor. And so I get a lot of questions of, oh, will DBS still be a good option for me? And the answer is yes, potentially, because it also helps with some of the dystonia symptoms. That's the painful muscle contractions that you can get as part of Parkinson's. It helps with the slowness of movement, stiffness of the muscles. So it's still something we want to look at even if you don't have tremor. Studies on the motor scores. So there's a rating scale called the UPDRS. So we've seen that the scores on that can improve 40 to 60% after DBS. Dyskinesia, so that's the wiggly movements that I mentioned, can be reduced by 60 to 80%. You can reduce your off time, so times when it feels like your medications aren't working, by 60%. And medications, this is another common question I get, is it a therapy that's going to replace my medications, or how much medication reduction can you get? And that is quite variable, but on average is about 30 to 40% medication reduction. So we do see people being able to take less medication less frequently, and then the key is that you're still getting, even if you're taking meds, still you're getting a lot better symptom control with that combination. So symptoms that generally wouldn't respond. So if these are your more bothersome symptoms with the disease, we would proceed with a lot more caution. If you have a lot of instability with your posture that again doesn't respond to the medications, we would be hesitant to say DBS is the right therapy. If you have a lot of speech changes that again don't respond to the therapy, then the medications, then it's less likely to improve with DBS. Non-motor symptoms, so that's a big category of symptoms that is anything from mood to blood pressure, bowel, bladder changes, and those are generally not thought to respond as well, although they're still looking into what kind of non-motor changes people can experience after surgery. Thinking and memory is definitely not something that improves after surgery. So we want to take a look at what symptoms you're dealing with pre-surgery and make sure we're targeting the right kinds of symptoms and doing it for the right reasons. So definite contraindications, if we do the workup and the testing and you have dementia, then that is not thought to be a good combination of worth it to take on the risk of surgery and get the right outcomes if you have that. And then we want to make sure that you have Parkinson's disease and not one of the other cousins of Parkinson's or atypical Parkinsonism, which has not been shown to respond well to DBS. Other things that we take into consideration when we're determining a good candidate is other psychiatric diagnoses, things that might interfere with how well you handle the surgery and the programming afterwards. If you get on like a good medication response, but still have a lot of disability, still have a lot of falls or balance problems, that's also when, again, like I said, with your posture instability or things that don't seem to be relieved by the medication, we would have more caution about doing surgery for that. And if you have a lot of other medical problems that would increase your surgical risk or infection risk, those are contraindications that we would think about. Age, there's not an actual cutoff of when we wouldn't do surgery. So we definitely like to take into account the individual. And if you're a young, healthy 70s or even 80s, that's something that we can still look at. But take into more caution and take that into account if you're in wiser years. So the workup that I was alluding to involves, quite an extensive testing, just again to make sure we understand, what the goals are of surgery, what your personal goals are. Make sure we do the right testing to find any red flags and determine what kind of symptoms people are dealing with and how well the medications respond to the symptoms. So something called on-off testing is where we do that rating scale where we have you tap like this and do this and look at your muscle tone, have you walk and do that first off medication. So you come in completely off your meds and then you would take your dose and then repeat that testing and look at the same things and get two results on and off tests. Scale results and look at the numbers, and you want to see at least a 30% improvement with the medication portion of the testing, because then we like to see that, which shows you're going to likely have more response to the therapy. And then it gives us a good sense of how someone's doing off their meds and on their meds and what kind of baseline disability people are dealing with. So we do that now. That testing's done through the Courage Kenny downtown, and physical therapist that we work with closely is trained to do that testing, and it's videoed. So when we have our meetings, we can review the video and see how someone looks as far as their movements in the testing. So that's really helpful to do. And then neuropsychologic testing, that's testing that looks at the thinking and memory side of how you're doing, and so gives us a good picture and make sure we're not missing a dementia, make sure we're not missing mood problems, that you can make an informed decision to move forward with surgery. That's important. And then also make sure the risks of surgery are worth it without risking worse outcomes or not getting the benefit that we're looking for out of surgery. If you haven't had a recent MRI, that's usually something we'd like to do within the past year. So that also is likely something we'll do as part of the workup. And then once that testing's done, so that takes 1 to 2 months to get those tests done after we had put in the orders and decide we want to do the workup. And then we meet as a team with the physical therapist, neuropsychologist, Dr. Nelson, myself, care coordination, and review all the tests and make sure we're all on the same page as far as patients' goals and whether those goals match what we're seeing on the testing and whether it makes sense to move forward. So again, we take a lot of time and thought and then also make sure the process moves through as smoothly as possible. So I'm going to shift gears to essential tremor. So that was kind of the Parkinson's overview of how we move through and discuss that candidacy. Essential tremor is a little different just because there's different medications that we use for essential tremor. And so there's different things we look at here. Essential tremor, slowly develops over years. And so we have medications that we can try, but they're not necessarily specifically designed to treat essential tremor, or they're more medications that have found to be effective to reduce tremor, but can run into side effects and lack of benefit, especially as the tremor progresses and gets worse over time. So people can reach a point where medications are no longer suppressing the tremor to the point where you can do your daily activities. You can't work, you can't do hobbies, you can't write, drink, eat without spilling on yourself. So if the tremor becomes disabling enough, people get to the point where quality of life is at risk. And so that's when we start looking at therapies like DBS, which can make a significant difference at reducing the tremor. And medications either stop helping or cause intolerable side effects. And so that's the kind of two situations where we would start looking at DBS. There's similar contraindications to what we look at with Parkinson's, where we want to do that neuropsych testing workup to make sure we're not missing a dementia or psychiatric problems, and have that good understanding of where someone's coming from with a background and understanding of the risks of surgery, look at medical history and age, and just try to, again, take everything into account before moving forward with surgery. But it is a really effective surgery for tremor. So this is an example of a baseline patient spiral, and then after their programming session with me and their spiral. So people go from not being able to get the pen on the paper or really struggling to being able to write again. And so it's a kind of powerful moment in the clinic when we get to do these programming sessions, and can be really effective. So fun to be a part of. Here's another flow chart to get an idea of how it works for the workup. So sometimes I'm already seeing patients that we decide, to move forward with these therapies. Sometimes that you're seeing an outside neurologist or physician, and then they get referred to me, or you get referred to me to have an initial consult. So at that appointment, it's very non-pressured. We want to go through everything with your Parkinson's or your essential tremor, and make sure we have an understanding of what meds you've tried, and if there's anything else we can do, other than surgery to help the symptoms. I address that at those visits. So it's not just about surgery, but we also talk about the surgery and benefits and risks, and go over that. And then if you decide, yeah, you want to move forward, we'll do the testing, do the team meeting, and then you would have a consult with Dr. Nelson in the clinic to have a discussion with him about the surgery and risks and benefits, and then be scheduled for your surgery after that if you still want to move forward. So after that's done, you would have an initial programming visit with me a month after the leads are placed. That's to let everything heal and settle in before I actually turn the stimulator on. And then after that initial visit, usually there's a few visits soon after that to make sure we fine tune it and get everything set. That ranges. It can take a couple of visits. It can take 6 months. It kind of depends on your symptoms and profile. Here is our team. So Kyle Nelson, myself, the good DBS coordinators, and people at Courage Kenny Physical Therapy have been really good to work with. And then neuropsychologists at Moran, Dr. Susan Cohen and Dr. Maida Gunther are the ones that do that neuropsych testing for us. So I will now pass it over to Dr. Kyle Nelson to talk about the surgery.
Good evening, everybody. Dr. Orehek did a nice job kind of sharing with you who's a good candidate for DBS surgery. And now I'm going to discuss a little bit about the actual surgery itself and some of the details and what to expect from a surgery perspective. What I always try and do is break open the black box of what is brain surgery. Obviously, as Dr. Orehek pointed out, this is a brain surgery. It does come with real consequences, and we'll get into that on a couple of slides. But we do not take this lightly. It is a major brain operation. The benefits that we see are tremendous, and that's why we are able to take some risks with this. But we do a very thorough process of getting patients fully evaluated before we decide to go to the operating room and proceed with surgery. And so what we're going to do with my portion is talk a little bit about some of the thoughts that go into surgery and then how we separate the surgery out. There are a number of different targets that we use for deep brain stimulation, and each of the targets has its own purpose. For essential tremor, there's really just one target, and that's the VIM of the thalamus. And that's just a very specific location in the thalamus, which is a deep part of the brain, to help control those tremors. With Parkinson's disease, we actually have two different targets that we use. One is called the globus pallidus internum, the other is the subthalamic nucleus. And again, each of these different targets will help patients in slightly different ways. Most patients would benefit from stimulation to either target, but depending on what your actual symptoms are, whether it's a tremor control, or maybe you're having those really bad dyskinesias on your medications, or maybe you have some dystonia, we can help with those symptoms. Apparently my slides aren't moving forward here. Let me see if I can do this.
Now it's working.
And now it's working?
Yep.
Perfect. All right, sorry about that. So like I was saying, we have different targets that we use for Parkinson's disease. And again, based on what your symptoms are, those are we'll choose a specific target to focus on those exact symptoms. And this is something we talk about in that consensus meeting that Dr. Orehek was talking about, where she's there and I'm there and the neuro psychologists are there, as well as the people who do the on-off testing. And we really try and narrow down what are the specific symptoms that we want to treat. And that goes into determining which of these targets we will choose. I like to do what's called a stage procedure for implantation of a full DBS system. And so really we break this up into two separate surgeries. The first surgery is focused on implanting the electrodes into the brain. Now that surgery is done awake, meaning that you're awake and talking to me throughout the whole procedure. Basically what we do is we get you back to the operating room, get you into this head frame. We use local anesthetic, basically numbing medicine, to numb up the scalp and the skull, and we'll implant the leads into the brain. Now, the reason we do this awake is because we want to actually test those leads when they're in the brain. And so that's kind of our final checkoff when we're in the operating room to make sure those leads are in the right spot. So we'll implant the leads into the brain. Generally, Dr. Orehek is here for that, or is in the operating room with us for that part. And we'll turn on stimulation and then have you do a lot of those tests that you did with the on-off testing to see if you get improvement. And sometimes you'll get improvement right there in the, or most of the time you'll get improvement right there in the operating room. If we do see any side effects or if we're not getting the stimulation that we want, we can easily move the lead one way or the other to make sure that it's in the perfect spot. Once those leads are in a perfect spot, we lock them into place and then move on to the other side. We generally implant 2 leads, one on the right, one on the left for most of our patients. Parkinson's disease, essential tremor are what we call bilateral diseases. It generally affects both sides of your body. Most patients will have one side that's more affected than the other, and that's okay because we can independently program those leads once they're implanted. But the goal of that first surgery is to get those leads into place and make sure they're in the perfect spot. Once those leads are into place, we close everything up and get you out of the operating room that day. We generally have patients off, for the Parkinson's patients, we generally have them off their medicines for that because we want to really see you at your worst. And so we want to make sure that when we're testing those leads, we're seeing you without any of the effects of your medications. Because I'm inputting something into the brain, we generally keep those patients overnight in the hospital because of the small risk of a hemorrhage. And again, we'll go into more of the complications here in a few slides, but there is a small risk of a hemorrhage. And if that happens, I want you in a place where we can diagnose that quickly and treat that if necessary. So I do keep patients in the hospital overnight after their lead placement. Once we're done with the placement of the leads, we can get you back on your Parkinson's medicine and get you up and move you around. And most patients tolerate that quite well. That procedure generally takes me about 4 hours or so. And that's from placing the patient into the head frame until we actually roll out of the operating room once those leads are in place. The example here that I have of some of the hardware, this is some of the new technology that we have. These are what we call directional leads, and this has really changed DBS surgery in the last couple of years. What we used to have is just 4 rings that would go around a lead, and we could only stimulate in a spherical fashion. What we can do now is we can actually pull that stimulation from one direction or another, again, to really focus on treating symptoms. And also, if we do have some side effects, we can steer away from certain parts of the brain to lessen those side effects. After we implant the leads, we admit you to the hospital. You generally go home the next day. Again, there's no stimulation. These leads aren't working at all. You're back on your medicines. And then we generally bring you back about a week later for completion of the system. Now, unlike that first surgery, it was done awake. This second part is a much faster surgery, and it's done fully asleep, meaning you have a breathing tube in place and you're under general anesthesia for the whole procedure. During this procedure, we connect those intracranial leads through what we call extension leads down the neck, and then put a small little pulse generator into the chest just below the collarbone. That surgery takes about an hour, hour and a half, and then that's done as an outpatient, meaning you go home the same day. Again, after that second surgery, your whole system is in place, it's connected, it's tested out, everything's working great, but we leave that device off. And then Dr. Orehek generally will turn that device on about 3 to 4 weeks after surgery for the initial programming. I do what's called a frame-based implantation, meaning that I put you in a stereotactic head frame. So when you come into the operating room, we numb up a certain couple little areas on your skull, and then that you're placed into this frame, like you see here in this picture. This is what's called a stereotactic head frame, meaning that in this head frame, we can get coordinates for any precise location, and then that gives us the trajectory to place those leads into place very accurately. We use some software from a computer called a stealth station to actually help us with programming and guiding those leads into place. So what you'll generally do is have an MRI scan about a week ahead of time. That will give me time to do the lead trajectory planning. And then when you come into the operating room, all we have to do is register your head to that frame, and then we actually get started by placing those leads into the brain. The way we register your head to that frame is we use what's called an intraoperative CT scanner, or this O-arm. It's a big machine that's actually a CT scanner that's mobile that we can bring into the operating room. And then we take about a 30 to 60 second scan of your brain, and then we can merge that with that preoperative MRI scan that we got, where I already planned the trajectories, and that'll allow us to get those coordinates for very accurate placement of the leads. Here's a couple of pictures from the actual operating room. you can see we keep this sterile, so this patient is awake. So on the other side of this drape here, they're awake and talking and looking around the room. And again, that's where we utilize the testing to make sure that those leads are in a good spot. So right here, we're implanting the lead into the brain, and then we're going to be testing this during surgery. For the Parkinson's patients, we also do something called microelectrode recording. And basically what that is it's using a very fine probe to go into the brain to look for certain signals of the brain. For both STN and GPI, we have very characteristic firing patterns of those areas of the brain. And so we want to find those areas before we put the leads in, again, just to confirm that we're in the right spot. Here's Dr. Orehek actually in the operating room. So this patient has a lead in place, and we're actually starting the stimulation process. And so she's testing their motor skills to actually see how they're improving with that lead stimulation. And of course, there's me in the background watching over to make sure everything's looking okay. Again, this is a major brain surgery, and we take this very seriously. There are complications that we can see with this. Most commonly, those are small hemorrhages. I always tell patients there's really 3 big complications you see with DBS. Complication number 1 is hemorrhage. Those risks are very small. It's less than 1%, but if it happens, they can be catastrophic. Again, knock on wood, we don't see this very often, but that's why I keep you in the hospital after surgery. I also get post-operative head CTs on all the patients to make sure that they don't have any areas of hemorrhage after the leads are placed. And so hemorrhage is one of the complications. The other is infection. Again, less than 1%, very low risk. But a lot of times if these systems get infected, the whole system needs to come out. And so we do everything we can to prevent infection, and that includes shaving people's hair. And so generally before we start that first procedure, I give you a nice little hair trim where we get all that hair off to prevent infection and help us make sure that we get everything closed up really nice. And then lastly, the other complication we have is some sort of complication associated with the hardware, or it just doesn't work. We get the device implanted, everything looks good in the operating room, we go to fire it up, and you have some sort of major side effect that you can't tolerate the stimulation, or the stimulation just doesn't help. In my hands and Dr. Orehek's hands, that's essentially 0. I would say all of our patients get some sort of benefit from their device. How much benefit they get is really what varies, and we have really high success rates with this. Again, as she pointed out, this is one of our favorite procedures to do and one of our favorite treatments to do for patients with essential tremor and Parkinson's because of the high success rate we have. When I see a patient, in the preoperative evaluation in my clinic and also in the operating room, we talk to them about how this is going to be life-changing for them. And some patients can't even comprehend. And when they actually do have the device implanted, many aspects of their life are much improved. Just simple things like eating or drinking a cup of coffee or playing cards with your family. All those things that they couldn't do before, now they can do. And again, these risks are real risks. They happen to patients. They happen at a very low risk or low rate, but they do happen. And I think the benefits that we see with DBS are definitely worth the small risks that we see. Again, touching on our program at Abbott, we've created a very comprehensive program. We are able to help patients from the preoperative evaluation all the way through programming and follow-up, long-term follow-up for those patients. It's a very efficient process. We worked hard. Now the pandemic has hurt us a little bit and our ability to get patients in, but we are able to do on-off testing very quickly, neuropsych evaluations generally within a month or 2. And then obviously we meet at a minimum once a month, sometimes even more often if necessary. If we have a number of patients that are waiting to get our approval, we'll meet sooner to get the process or keep the process moving for those patients. And then again, once we get the patients into the operating room, most commonly we do bilateral lead placements, which we are the only location in the Twin Cities that does that. Most other places will do unilateral lead placements, meaning they'll put a lead in on the left side and then bring you back a month or a couple of weeks later, or sometimes a couple of years later, and put the other lead in on the other side. The amount of time it takes for me to implant another lead during that same process is about 30 minutes. And so we feel that that's worth our time to implant that lead. Almost all of our patients benefit from at least some stimulation on the other side. And again, we can independently stimulate each of those leads. And so it makes sense just to implant both leads at the same time, because most patients will benefit from that bilateral lead placement. We have multiple locations where we can see patients throughout the Twin Cities. We do all of our surgeries at Abbott, and so there is a fair amount of time that you will spend there, both for your on and off testing, obviously surgery, but then for follow-up appointments and programming, you can work with Dr. Orehek at any of the locations that she goes to. Again, we have at least monthly multidisciplinary consensus conferences. So again, we try and keep patients moving through the system. We have excellent results. And then, of course, we do many community educational events like this throughout the year. We also go to many of the support groups, and we'll give educational advice to those patients, not only on DBS, but also evaluation for DBS and other Parkinson's and essential tremor treatments. Again, just in conclusion, DBS surgery, although it does have some risks, it's very safe, it's very effective, and oftentimes it's life-altering for patients. They can't even comprehend the things that they can do after surgery that they were unable to do before. Many of them thought that they would never be able to do certain things with their family or certain activities that they enjoy doing, but after DBS, they're able to accomplish that again. And so that's very rewarding for us and obviously for those patients. If you guys have any questions after this, and again, we'll have a little question and answer session here in just a sec, but if you have any other questions, there's a lot of good resources for you. The Alina website through Alina DBS has a lot of information, and these programs are recorded and saved there. The Naran Clinic also has some good information. And of course, Anushka is always a good resource to, if you have specific information or need to find a way to get in to see us, she can help coordinate that. So with that, I think that's all I have for a formal presentation. If anybody has any questions, both Dr. Orehek and myself would be open to answering questions for things that we didn't cover.
I'm not sure who would be able to address this, but why is there such a long waiting period for the final programming?
So that's a great question. So what we found is that that 3 to 4 weeks that we wait in between the implantation and the initial programming, it seems like a long time, but there's actually a lot going on in your brain. So when I implant those leads into the brain, there's a small little area around the brain where there's no brain, and so there's it's mostly CSF or some air that's in there. If we started programming right away, we'd have to increase the stimulation quite high to sort of bypass that that area. After about 3 or 4 weeks, the brain is fully healed up and scarred down around those leads, and so we don't have that same increase in stimulation that we'd have to get through that area. And so instead of increasing the stimulation to get through that little bit of fluid to actually get the treatment result, and then that probably being too high of stimulation, and then decreasing the stimulation and kind of chasing our tails through that programming process, we actually just wait the 3 to 4 weeks, and then we can just slowly increase that stimulation to get the desired benefit and don't have to go kind of back and forth. And so we found that to be actually much more effective and much more efficient than going back and forth over a few months to get the desired results. But yeah, great question.
Thank you. Another question, if you don't mind.
Yeah.
Specific parts of the brain, I mean, are you actually going through the whatever parts of the brain just around the ventricles, or do you go like, is there a pathway that you always use, or?
Yeah, that's another great question. And so each trajectory is a little bit different based on the specifics of the patient and the specific anatomy that they have. Generally, what we try and do is go around the ventricles. The size of the catheters are about the diameter of a coffee stirrer. So they're about 2 or 3 millimeters in diameter. And so they're very small. They don't cause any damage to any of the brain that they go through. But we pick a pathway where we're avoiding some of the major blood vessels to, again, decrease the risk of that hemorrhage, but then staying in the brain all the way to that target so that those leads aren't moving around or fluctuating with any changes in your spinal fluid and things like that. So the overall trajectory is fairly stable or fairly consistent amongst patients, but the individual trajectory can vary by a few degrees, both anterior, posterior, and also side to side, medial or lateral, depending on the patient's specific anatomy.
Is there any rejection problems because of this foreign object in your body?
That's a great question. I have seen one case where there may have been an allergic reaction to, it's generally not the leads, those tend to be pretty inert, but it's the actual pulse generator. And again, that's all metal, so some people can react to this. I've seen one case of probably 1,000 patients that I've ended up treating in residency and in training that I've had to take this out. And actually wasn't even my patient, it was a patient of somebody else, another surgeon, that I had to remove their device. And I'm not sure that even that they had a true allergy, but they were having a lot of symptoms of an allergic reaction, and their device wasn't working well. And so it ended up making sense just to remove the device to make sure that wasn't a problem. But that's a very, very rare issue that we see.
Thank you.
I was wondering, can you address any of the side effects that we would be anticipating maybe?
Yeah, so in the operating room, we actually try and elicit those side effects. So what we do is actually push stimulation past where we normally would stimulate patients to try and bring out some of those side effects. A lot of times it can be some speech issues. So patients will have a tough time getting their words out. It'll feel like their tongue is full or their kind of face is pulling. Sometimes we can see that. Sometimes patients will have some tingling or numbness in their hands. Sometimes they can get double vision. Those are all some things that we look for while we're doing the testing to make sure that that lead's in a good spot. And again, with some of the new technology that we have with these directional leads, even if we're getting some of those symptoms in the operating room, we can oftentimes, as we fine tune that programming, eliminate that when those patients are actually in the office and we're doing the final program because of the directionality of these leads.
Yeah, so that's something, side effects is something that we look at closely also during the programming session and our temporary. So if I push the stimulation up too high and start getting slurring or start getting tingling, if we back off, it goes away. So you're not left with bothersome side effects. And then again, we try to find the right balance. And it's pretty amazing that the difference, just shifting that current a few degrees or a millimeter in the brain makes as far as how many side effects and then benefit you get. So we have a lot of good options in programming.
One kind of a not so serious question, but since you're able to do this to diminish the symptoms of the Parkinson's, can you ever find the place where you could stimulate it to increase the memory and cognition? Just wishful thinking.
Yeah, they not the same target for Parkinson's that we use now, but there have been that kind of research stimulating other areas of the brain, trying to improve memory and bring back memory. So there are stimulation areas that have led to some of that or moved treatment of depression, but not something that we're directly involved in.
Is there any restriction to future MRI or other imaging because of the implant, or is it generally compatible?
Yeah, so the system, most of the systems now, or all the systems now are MRI compatible. So there's a rare situation where there's a open circuit where we can't do an MRI. There are some conditions that we have to follow. So there's less places that can do an MRI once you have DBS. And so that creates a little bit of work and barriers to getting one, but you are still able to get one, and then you just work closely with the physician to get that set up and coordinated. And then the device company has good tools to make it MRI safe.
How long does the device last once it's implanted? Does it ever need to be replaced?
So the leads that go into the brain don't need to be replaced. Those hold up well. The parts that need to be, the main part that needs to be replaced is the stimulator, the generator battery. So that there's different options there's non-rechargeable options that last 2 to 5 years. There's rechargeable options that last up to 15 years. So that, depending on one of the discussions that we have and that you'll have with Dr. Nelson in the clinic is what type of system you want and what type of battery and pros and cons of getting a non-rechargeable that you don't have to charge, every week, or a rechargeable that lasts longer, but you have to keep it charged up. So there's plenty of options, but also discussions that we have individually with patients.
Can you have this procedure if you have a pacemaker?
Yes, you can. If we can't get an MRI, it's very challenging to do the targeting. So if your pacemaker is MRI compatible, then it's definitely doable. We just put it on the other side.
Okay, thank you.
I have a question regarding some therapy that I'm going to be on track to do. I'm going to be doing TMS, transcranial magnetic therapy, magnetic stimulation. And if this device was implanted, would that be not an option in the future to be able to do the TMS?
Yeah, that's a good question. And I believe it would be contraindicated if you had DBS and not being able to get the TMS.
Okay. Does the DBS help in some ways for, say I'm considered right now to be treatment resistant for medications for depression and anxiety. And so that's why I'm doing the TMS, but does the DBS help provide any relief for depression or anxiety, or is that mostly just targeted for Parkinson's motor symptoms?
It's mainly designed to target Parkinson's motor symptoms. We can see improvements in quality of life, and then that can follow along with improvements in depression and anxiety, depending on how much your Parkinson's motor symptoms are impacting your mood. So if it's a kind of separate depression, anxiety thing that you're dealing with, it's definitely not something that we look at as improving or treating depression and anxiety.
Okay.
But people's mood can improve just because they're feeling so much better and doing better.
Mm-hmm.
Good questions. We also get questions about insurance coverage usually, which it generally is covered well. So Dr. Nelson's staff deals with that once you see patients, and then they handle the authorization, and that usually goes through, right?
Yeah, and we, through the process, our preoperative evaluation, we satisfy most of what the insurance companies would require for DBS implantation. So the on-off testing and the neuropsych evaluation are oftentimes things that they need. And obviously we do that as just part of our normal workup anyway. So most of that's done, already by the time we do our pre-authorization. My office does take care of that. So they will send to the insurance company, whatever codes we would be using, and then get an approval for that before surgery. So most patients don't have to do that on their own. We would take care of all that. Obviously reach out if there is any problems.
Lori, are you raising your hand for a question?
Yes. Can you hear me?
Go ahead. Yep, we can hear you.
How much does that surgery cost about?
It really totally depends on your individual insurance coverage.
Right.
So it's generally very well covered by all the major insurance companies and Medicare and Medicaid. And so whatever your out-of-pocket deductibles are is what you would be responsible for as an individual generally. So it's hard to say. There's not just a number. It's really what your individual coverage is and how much you spent up to that point in the year and things like that.
Thank you.
Mm-hmm.
How often does a person need to see the specialist or the neurologist after the surgery?
Yeah, good question. So more often right away, because you do that initial programming a month after the surgery. And then I try to bring people back monthly while we tune things up. Sometimes we can get it dialed in and it, like Dr. Nelson referenced, with some of the image guided programming we can use and some of the new directional, we're able to dial it in faster. And so that time frame is changing a little bit, but usually it's a few visits right in a row that we do, and then can space it out. And then I like to keep an eye on the device and how people are doing at least yearly. And it depends if you have a separate neurologist that's checking in too on other things. But I follow my Parkinson's and often essential tremor patients every 6 months. So that's generally the schedule we'll follow after the surgery.
I have a question. We live in Duluth. How many trips will we be making to Minneapolis, and will any of these take part in Duluth, or do we have to go to Minneapolis for everything?
Yeah, another good question. We have started partnering more with patients from Duluth, and so we're trying to help make it more patient-centric and not have you drive down all the time. The on-off testing you do have to come down in person for, because we have just the specialist physical therapist that knows how to do that. The neuropsych testing you could do locally, or we could try to do a virtual telemedicine neuropsych testing. So that would cut down. So that would be at least one physical therapy on-off visit, a visit to see myself in consult and Dr. Nelson in person. We like to do in-person visits for those, just because there's a lot that you can't do virtually that help to be an in-person visit. And then the programming sessions afterwards, it depends also if you have someone locally that's doing the programming. So I think up in Duluth, they do have that set up where you can go back for the programming session. So it would be just a few preoperative visits.
Okay, thank you.
And they generally help me out too with like taking sutures out and things like that. So we have those relationships with them and generally can work that out. Obviously, if there's any issues and things like that, we have to bring you down so I can look at incisions or chat with you if there's a problem. But other than that, we can take care of actually a lot of stuff remotely with our partnerships with them up there.
Yeah, and there have been direct referrals right to Dr. Nelson even without seeing me first too. So that's also an option. It just depends on how much they want me involved prior.
Yeah, and some cases are a little bit more complex than others, and that's where they rely on Dr. Orehek specialists or specialty to kind of help them figure that out too.
Thank you.
Thank you, guys. Have a good evening. It's been very helpful.
you.
Thank you.
Good, you're welcome. Take care.
Perfect. Thank you, everybody, for joining us.
Thank you. It's very informative.
Good. Have a good night, everybody.
Yep.